I'm Maria Martinez, a population health postdoctoral fellow here at the Minnesota Pop Center. It's my pleasure to be helping out with this session on longevity and mortality. Welcome back from lunch and thanks for sticking around. I'm going to briefly introduce all of our presenters. First, we'll be hearing from Dr. Hamid Noghanibehambari on walking with feet tied to the past, childhood exposure to the 1918 influenza pandemic. Dr. Noghanibehambari is an assistant professor of economics at the Austin Peay State University. His research interests are health economics, environmental economics, and economics of education. Next, we'll be hearing from Dr. Sarah Meier, who will be presenting on the impact of wildfire smoke exposure on excess mortality and later life socioeconomic outcomes. Dr. Meier is a postdoc at the University of Exeter in the UK. She is an applied environmental economist with a background in climate sciences. Her research focuses on the intersection of these two disciplines with an emphasis on natural hazards and biodiversity. Unfortunately, Chris Soria couldn't join us today. So next we'll be hearing from Ruchira Chakraborty on the multidimensional healthy life expectancy and counting years of good life among older adults in India and its subnational populations. Ruchira is a scholar of demography at the International Institute for Population Sciences in India. Her research area is focused on population aging and health outcomes, the need for care of older people, and associated healthy life expectancy. Finally, we'll hear from Dr. Jiaxin on citizenship and immigrant longevity, evidence from the US Census-linked Social Security Administration death records. Dr. Shi is a postdoctoral researcher at the Center for Demography of Health and Aging at the University of Wisconsin-Madison. He received his PhD in sociology from the University of Oxford in collaboration with the Max Planck Institute for Demographic Research. His work examines health inequities, focused on how these inequalities are related to population dynamics and processes of social stratification. And with that, I'll turn it over to Dr. Noghanibehambari.
Okay. Good afternoon, everyone. I'm delighted to share my research with you. The paper I'm presenting is titled Walking with Feet Tied to the Past Childhood Exposure to the 19 Influenza Pandemic and Later Life Mortality. And this work has been done in collaboration with Jiaxin Fletcher. So the infamous Spanish flu was one of the deadliest pandemics in recorded history. About 1/3 of the world's population contracted the disease. About 50 million deaths occurred worldwide. In the US, there was estimates of about 700,000 deaths. The US economy experienced 1.5% drop in GDP and about 2% drop in aggregate consumer expenditure. The age distribution of this pandemic was a significant departure from the typical pattern. We experienced high mortality rates among infancy, then low mortality regime for childhood ages up to age 16, 17, and then the mortality increased for early adulthood up to ages 26, 27, and then dropped, so forming a kind of a W-shaped mortality pattern here. And it's important for my findings, I will discuss later. There is a strand of research that explores the later life impacts of exposure to this pandemic during in utero and early life. The research in this literature usually implements a cross-cohort analysis focusing on the impacts of in utero exposure versus the adjacent cohorts exposure, and find reductions in income, education, increases in disability later in life, also deteriorations in subjective and physical health outcomes for those in utero exposed cohorts. A narrower strand of this research examined the impacts on later life mortality. For example, Fletcher 2018 implements the same cross-cohort comparison and shows that, consistent with prior literature, these cohorts experienced reductions in income and education, however, no impact on mortality. Meier et al. 2012, the same method, similar data, finds that in utero exposed cohorts reveal increases in non-cancer death, but reductions in cancer-related mortality outcomes. Therefore, as we see, this literature on mortality is mixed, inconclusive, and we want to reevaluate this literature. The main departure of our study from these studies is that, as I discussed, the literature focuses on a cross-cohort comparison, which means that everyone born at the same time receives the same treatment, right? And they focus exclusively on in utero. They assign a treatment for in utero exposure. So we implement a difference in difference analysis, exploiting within cohort variation for those who were born and experienced their childhood in different mortality cities. So we have some intensity of the treatment within the same cohort. And also we flexibly examine the effects across different ages rather than focusing exclusively on in utero effects and exposures. In addition to that, the nature of our data allows us to control for family characteristics, and prior studies show that controlling for family confounders is important in studies that examine later life impacts of the 1918 influenza pandemic. The primary source of data comes from the death master files, DMF data that reports death that occurred to male individuals only between the years 1975 to 2005, extracted from the Census project. It is linked to the 1940 census, extracted from IPUMS. We linked 1940 census to earlier full count censuses 1900 to 1930, again extracted from IPUMS in order to infer city of birth and childhood of individuals. For that, for cross-census, we use the census-linking project linking rules. City-level influenza mortality data comes from Beach et al. And we focus on several cohorts born after the pandemic and many cohorts up to age 20 born pre-pandemic. Therefore, birth cohorts of 1898 to 1926 for about 500 cities across the US. The final sample size is about 1.5 million. The empirical method is a standard difference in difference, where the outcome is the age at death measured in months for individual I, in city of birth or childhood C, in census region R, who belong to birth cohort B. We have a series of dummy variables indicating cohorts relative to 1918. In other words, different ages at 1918, different ages at exposure, interacted with an exposure variable, which is based on influenza mortality rate during the years 1918, 1919 at the city level. So high mortality cities versus low mortality cities interacted with different ages at exposure at 1918. We have some individual covariates, family level covariates, and some city level controls. In addition to that, we have birth region by birth year fixed effects and city fixed effects. So this figure summarizes the findings of our paper. The negative coefficients here refer to those born post-pandemic, and the positive coefficients refer to different ages at exposure. We observe that those born around in utero, early life, their longevity is not statistically or economically different than those born post-pandemic. So there is no impact for in utero exposure or early life exposure. However, as we move the age at death to ages 2, 3, 4, 5, all the way to around 12, 13, we observe negative and significant impacts on longevity. The coefficients remain negative and well comparably sizable for ages at exposure of here 14, 15, 16, 17, and 18, 19, but they are statistically insignificant. The overall pattern is the largest impacts coming from childhood exposure, middle childhood exposure, rather than in utero or late adolescence exposures. To have some numbers, I group those age at exposures into 3 groups, 0 to 5, 6 to 11, and then 12 to 16 interact with exposure measure. And the fully parameterized model is reported in column 4. We see that age at exposure of 0 to 5 is associated with about 1.8 month reduction in longevity. The largest impacts coming from age at exposure of 6 to 11. And then for the 12 to 17 age group, we observe much smaller, 0.19 months, negative, but statistically insignificant impact. Now, there are a number of mechanisms to consider that it can explain the observed impacts. For example, business closures that could affect employment outcomes, income outcomes, or school closures that could affect educational outcomes, or the barriers to healthcare access that could affect people with pre-existing condition, or the general anxiety in the air, the mental pressure, stress outcomes, or this lack of barriers to social interactions among children that can affect their socio-emotional outcomes, cognitive development outcomes, etc. And a number of these pathways can have reflection on human capital development. We use 1960 to 1980 censuses and look at schooling and socioeconomic index outcomes. For schooling outcomes, you observe that these children reveal statistically significant and negative impacts for exposure during childhood to the pandemic. Interestingly, the largest coefficients coming from age at exposure of 6 to 11, for whom we observe largest drops in longevity later in life. So part of this can be explained by schooling outcomes. Now, Halpern Manor et al. 2021 have a paper in which they show that each additional year of schooling is associated with about 3 to 4 month increases in longevity. Using their estimate, my main results estimates on longevity, and this table, we can do a kind of back of an envelope calculation and show that about 30 to 40% of the observed drops in longevity can be explained by this human capital pathway. There are other mechanisms, but 30 to 40% is a really significant portion of that effects can be explained by this human capital drop. So to conclude my presentation, we didn't find any impact for in utero or early life exposures, which we know that it's a very high infant mortality regime. And so part of those scarring effects could have been canceled out by the selection effect for infant mortality. But we did find significant impacts of childhood exposures. Now, using those numbers in my table, 1.8 and 2.7 month drop for age of exposure of 0 to 5 and 6-11, using the number of all exposed individuals in the final sample, we can do some kind of a back of an envelope calculation and show that there are about 94,000 life years lost due to childhood exposure to the pandemic. Putting this into some numbers, monetizing this value, we can use value of statistical life estimates and calculate a total loss of about $12 billion only for people in the final sample for an intent to treat estimates as reported for the longevity outcomes in the main results. And overall, these findings offer important policy implications for interventions, for identifying population at risk of adverse long-term outcomes during major pandemics. Thanks.
Hi, everyone. Thanks for sticking around. And Rob, thanks for flagging this presentation. I hope I can halfway live up to expectations. So this is joint work originating in my PhD together with my former supervisors, Eric Strobl and Robert Elliott at the University of Birmingham. And so wildfire activity has increased in many regions across the world in the past few decades. We had extreme wildfire seasons in California and then last year in Canada, leading to images like this in New York last summer. And so there's a significant contribution of wildfire smoke to ambient air pollution. So we're worried about a range of health effects, including respiratory morbidity and mortality, then cardiovascular morbidity, all-cause mortality, and neurological effects, usually measured through cognitive performance. So the question is, why do we study a historical event? And I'm glad that for this audience, I maybe have to less emphasize this. So it can be seen as a historical precursor to the recent surge in extreme wildfire events. Second, health effects at the time were kind of undervalued, so people didn't really try to avoid smoke. And third of all, so going back in time allows us to evaluate these potential time persisting effects. So this is what we couldn't do with a more modern setting. So our research question is, what is the impact of wildfire sourced smoke pollution on excess mortality and then on later life socioeconomic outcomes? The event is the Great Fire of 1910 that occurred in the Northwestern United States. I'm going to show it on a map in a minute. And it was one of the largest wildfires on records, if not the largest. In terms of data for the smoke exposure, we start with a historical burned area map, and then we model the smoke emissions and dispersion. The mortality data we get from ancestry.com and related web pages. And for the socioeconomic indicators, we use the IPUMS full count census data from 1900 to 1940. We focus on the children under the age of 5 because they're particularly vulnerable because of their ongoing development. For example, children breathe more air relative to their body weight compared to adults. And there's a lack of studies in the wildfire area for this pediatric demographic. And unlike the vulnerable elderly, children can easily be tracked over time to study these potential longitudinal effects. In terms of identification, we look at wildfires as being endogenous to our outcome variables because lots of wildfire occurrences are correlated with human activity. And so we do the smoke modeling using exogenous meteorological inputs, mostly wind speed and wind direction. And we additionally control for the directly burned area. So this paper got 2 parts. In the first part, we look at short-term excess mortality using a diff design. And then for the later life socioeconomic outcomes, we have a cross-sectional analysis that is conditional on controls. So this is the map of the United States. And so the orange area is where the fire occurred in the intersection of the states of Washington, Idaho, Montana. And then the darker shaded blue area is our study area with the 70 counties that we're looking at. And Connecticut is colored in orange because that is about the size of the fire. And I want you to imagine that all these area burned in just about 2 days, which is just unimaginable. And I don't think this has been matched in any of the recent years. So the spring and summer leading up to the 1910 fire were incredibly hot and dry. On the map, you see temperature anomalies, and these conditions weren't met till like 2012. So really extraordinary. And then the US Forest Service, who was like a very young institution founded in 1905, was short-handed with hundreds of small fires. And on the 20th of August, the hurricane force Palouse winds just swept over this area and merged all these small fires into one massive firestorm. And it was only on the August 22nd where a cold front brought like early steady rain and early snowfall that then extinguished this massive firestorm. So in terms of data work, so this is the historical burned area map we're starting with, and then we georeferences using state borders and delineate each of these burned area polygons. For the wind modeling or smoke modeling for modern study, we could use satellite imagery or ground monitoring stations that we can't do for 1910. So what we do is using a modern smoke modeling framework called Blue Sky Framework, and we feed in historical information. So it's got 2 main parts. On the right-hand side, we first model the emissions, and then in the middle column, we model the dispersion using Gaussian plume modeling of the smoke. And everything that is colored is where we deviate from the default settings or where user input is strictly required. So for example, for the emission side on left-hand side, so we define the fire type as a wildfire as opposed to a prescribed burn or an agricultural fire. Then we know the geolocation of each of these polygons, and we select what type of forest there was and like how dry the fuel was and so on. We get an emission report, which we then feed into the second step, where we look at the meteorological conditions, and that leads us to the dispersion results, which is peak hourly PM2.5 concentrations for 6 different hazard classes. So we do this smoke emissions and dispersion modelings for all of these 176 burned area polygons and merge it into one big plume. Actually, we do 3 different plumes for different hazard classes. But as you see, like most of the area was just at the peak level, which is about, I think, roughly about 526 grams per cubic meter. So this led us to just like have an indicator variables of the counties that were smoke affected, which leads us to our treatment group here in orange, the smoke affected counties, and then the blue counties are our comparison group. So first I'm going to look at the short-term effect of excess mortality. It's always just on the children under the age of 5. For the mortality data, we got the data from Ancestry.com. And what we do is for each county and year between 1905 to 1910, we search for these death certificates. We usually get the exact date of death, the name, first name, last name, age, sometimes gender. And then we aggregate this to weekly county level panel data set. Because we don't only want mortality counts, but we want mortality rates, we use the IPUMS full counts censuses to then interpolate the weekly mortality data from 1900 to 1910. We do some county boundary adjustments, which is a bit tedious, but it works. And then so we get our mortality rates, and because we're interested in excess mortality rates, we take the 5 prior years, we calculate this weekly moving average for the 5 previous year to get our baseline mortality on the county level. And then we calculate the excess mortality rate by subtracting this baseline mortality rate of the previous 5 years from the actually observed mortality rate in 1910. So we estimate a dynamic two-way fixed effects difference in differences model, including 8 pre and 8 post periods. So that's roughly 8 weeks. So that's roughly 2 months. Our outcome variable is the excess mortality rate in county I and week T. We normalized the pre-period to 0, and then we got an indicator variable whether the county was smoke affected. And we also get an indicator variable whether there was burned area in the county to control for these potential direct effects. Well, we got county level effects, fixed effects, weak fixed effects, and then we're just interested in the lags. And we're also studying the leads to see if there were any prevent differences. So we find this positive effect of smoke exposure on the excess mortality rate in the fire week. So that's week 0 of 35 per 100,000. So that's 35 children under the age of 5 per 100,000 children under the age of 5. This corresponds to an increase of about 190% relative to the average weekly mortality rate in 1910. And so we're interested in what happens in later life for children who were smoke exposed in their early life. Here we use the IPUMS full count census, individual household data from 1910 to 1940. We use the Census-linked projects for the crosswalks, but as I learned, we're gonna see how it looks with all the different types of crosswalks. So lot to look at. So we evaluate the socioeconomic status outcomes of roughly 8,000 men who were under the age of 5 in 1910. And we look at these composite measures and dimension-specific measures of the socioeconomic outcomes, all of which are based on the occupational classification scheme in 1950. Here we run ordinary least squares regression, where our outcome variables is the socioeconomic status in decade D of individual I that resided in county C in 1910. We again got the same indicators for smoke affected and for burned area. And then we control for whatever aspects or characteristics that we think could influence the socioeconomic outcomes as well. So on the individual level, that's race and nativity, and for the parental characteristics, that would be mostly information on the father, because the mother is rarely in the labor force. Then we get all these household characteristics. We use the county level data to kind of characterize the counties and got state indicators. And so in 1930, that's when these boys or men are between the age 20 to 25. We find that these composite measures are negative and significant. So boys who were smoke affected in their early childhood on average rank lower than on these socioeconomic outcomes than boys who are not. And then 10 years later, so this is 1940, we see that smoke exposed children rank on average or have lower average in annual income of about $90. This corresponds to a 3.6% reduction relative to the sample mean. We do a bunch of robustness checks. I'm not going to go through them. I know economists love them, but I know not everyone is an economist, so I spare that. So here's the link to the working paper that we put out if anyone's interested in knowing more details about this. And thank you very much.
Hello, everyone. First of all, I'd like to thank the organizers for having me here and providing me this opportunity to attend the workshop as well as present my research. Not all of us, but most of us is interested in US data and deliberately walking into those data and in US population. So I want to grab this opportunity to talk about Indian population. This is a part of my PhD I'll be presenting today. It's an ongoing working paper, so all the comments are welcome. We all know that Indian population is still young, it's true, but the major share of older population is increasing at a relatively faster pace. So it's better to think about the older population earlier and have some insights on them. So I'll be presenting on multidimensional healthy life expectancy and counting years of good life on Indian older adults and its subnational level population as well. So to begin with, as a consequences of unprecedented rise in life expectancy and result of population aging, research on life years spent in different health conditions, good or less than good or poor health, and its consequent human well-being and silver dividend gain significant importance globally. Though rising life expectancy itself is an indicator of development, but it does not really include the quality of life dimensions into it. So here comes the healthy life expectancy concept. And a recent study published in Population and Development Review says that if we study the across countries comparison, compare the across country healthy life expectancies, then the inequalities in health across the countries have subsided, but within country health inequalities have increased. So understanding health, especially for later life, holds a major importance for aging country like India, as I was saying, to ensure whether the increased share of older population would contribute to the productivity gain, that is silver dividend, or rather it will lead to rising dependency, economic and healthcare burden on the state. So there exist different summary measures of health to understand healthy life expectancy, such as prevalence of disability, presence of non-communicable diseases or multimorbidity, self-rated health, or limitations in daily activities, or some other subjective well-being aspects as well, such as happiness that leads to formulation of happy life expectancy or happy planet index, etc. But all these indices either focuses on some subjective dimensions or objective dimensions. But we are now adopting a new index, that is years of good life, that was published in PNAS and proposed by Wolfgang Latz and colleague by IASA. So it is an amalgamation of both subjective as well as objective concepts. So this is the conceptual framework. The outer circle represents the whole life expectancy, whereas one of the circle denotes the objective aspects, and another one is representing the subjective aspects, and the intersection of the Venn diagram represents the years of good life. And so there are 4 components. First 3 are the objective dimensions of health, that is poverty, cognitive ability, functional health. And the 4th one is life satisfaction, that is the subjective aspect of health. No, sorry. Yeah, so understanding poverty, unfortunately, Indian data on income is not that reliable to understand poverty. So the survey is relying on the household consumption data. And to understand cognitive ability, mini-mental scale examination, or say MMSE, has been used. And to understand functional health, the activity limitations such as difficulty in getting out of bed, making a meal, or bathing, such as this sort of work that are having any limitations are taken into account. And to understand life satisfaction, that is a single question, and a respondent is asked to rank his life in a Likert scale and how satisfied he is with his life. So, a year is counted as a good year if a respondent is out of poverty, out of any cognitive limitation, out of any functional health limitation, and with positive life satisfaction simultaneously. Okay, so the data source is survey data, that is longitudinal aging study in India, though it says longitudinal, but currently only the wave 1 data is available. Wave 2 is ongoing data collection is going on. So the survey is kind of a sister survey to HRS, which is in US, and it includes information related to demographics, household income status, health condition, biomarkers, and healthcare utilization, family, social networks, etc. And the sample size is quite big, as India is a big country, and it's a state level representative sample as well. So the total sample is 72,242. And the age group, the respondents are eligible, is aged 45 years and above. And for the life expectancy information, the death registration is yet not complete for Indian population. So the the information regarding mortality is taken from SRS, that is Sample Registration System provided by Census of India, and average life table for the time period of 1718 are adopted. Now, as this is a prevalence-based method, so Sullivan's method of life table construction has been adopted, and it's a simple one where to understand life expectancy, we use life table. And in Sullivan's method, the mortality rates are replaced by the proportion of population above the threshold level of good life. For example, if we see at age 45 to 49, the proportion of population above the threshold level is around 57%. And so what this RLE represents is remaining life expectancy after attaining age 45. So we can see for national level population, after attaining age 45, the remaining life expectancy is 30 years. Within the 30 years, only 13 years, that is around 44% of the remaining life expectancy, can be counted as good life. And with increasing age, it will definitely decrease, but it's decreasing at a faster pace. Like at age 45, though not half of the remaining life expectancy, but closer to half can be counted as good years, but it declines to 19% to population at age 85 plus. Okay, so after computing the years of good life for all the states, we found there are heterogeneities within the states. So to understand what is impacting the heterogeneities, we have used a regression-based decomposition model by Schrox and Fields. So in the beginning of the model, including all those 4 aspects of the index, we have included some digital factors as well, such as level of literacy, widowed population, share of widowed population, then share of population belonging to any minority group, such as different caste and religion, etc. And then we have predicted the probability of having a good life. And then we try to explain the covariation along with all those affecting factors. So this is the prevalence, age-wise prevalence of proportion of population who are above the threshold level by male and female. And this is for rural and urban population. And now this graph interprets the share of good life in remaining life expectancy. So the lowermost line is for female and the uppermost line is for male. So we can see that for each age group, there is a huge gender gap. And at age 50, we can see that the male population have more than half of their remaining life expectancy as good life. But female, for female, it's never up to half of the remaining life expectancy, not any of the age groups. So this is a map showing the heterogeneities in different states. So the darker the shade, the higher share of good life. And so for male and female population, we can see that for all the states, the female are at a lighter shade, and male and urban population are a little better off. And there is a concentration of higher good life that is in the northwestern states. But the intriguing factor is that if we understand the burden of non-communicable diseases or disabilities, that is not that, that is much more higher in the northwestern states. So if we only solely depend on the physical disability or the prevalence of diseases, these states are not coming at as good as it is coming on the good life. As we are we are incorporating in the poverty dimensions and subjective well-being, these states are performing better. And this is the rank concordance and discordance graph. So in the left column, the life expectancy at age 50 and its relative rank of states are presented, whereas in the right-hand side, it's the years of good life at age 50. So it shows that few of the states who have relatively higher rank in terms of life expectancy are showing that they are having a higher share of good life. But there are huge rank discordance in between few states. I want to share that those states that are performing very low at years of good life, that is not concentrated in any portion. The first state, that Tamil Nadu, is from the southern part of India. Maharashtra is from western part of India. Odisha is from eastern part of India. So there are huge rank discordance in terms of life expectancy as well as in terms of years of good life. Yeah, thanks. So after decomposing it for the total population, we can get that the functional limitations are contributing a major share in heterogeneities across the states. But if we decompose it in different strata, then we can see that for male also the functional limitation are contributing a larger share. But for female, the age group, the birth cohort they are belonging to is contributing higher share. And for rural and urban population also, the functional limitations are contributing higher proportion, but followed by the cognitive impairments. Okay, so to conclude that this article tried to add a significant value in literature related to capturing quality of life and inequality in healthy life years across the subnational population of India. It highlights that concordance between longer life and years of good life is not consistent. It's not always consistent for all the states of India. And female life expectancy is higher. And for India, it's true since 1981. But this finding supports the male-female health mortality paradox. That is, female have higher life expectancy, but that highest share of life expectancy does not always turn into good health. So they are more vulnerable to live longer years in a bad health. And so regional variation in terms of YoGL is much higher than the variation in life expectancy. So that's all from my side. Thank you.
Good afternoon. So this starts from the considerable interest among social science researchers in understanding the differences in health and longevity between migrants and non-migrants. But the heterogeneity in health within the migrant population remains relatively understudied. An emerging area of research has highlighted that the health of immigrants varies by immigrant characteristics, such as SES or country of origin. Despite these insights, one aspect that remains relatively underexplored is how the political standing of immigrants may influence immigrant health. Previous research has examined effects of immigrant legal status on immigrant chronic conditions, mental health, self-rated health, and prenatal mortality. We contribute to this literature by providing the first assessment of the effects of citizenship on immigrants' long-term mortality outcomes. And this is joint work with Jiaxin Fletcher, also from UW-Madison. And we use the same data that Hamid has used in their research. So we are looking at immigrants who lived in the early 20th century America and died after 1975. We answered two straightforward research questions. Does citizenship affect old age mortality for first-generation immigrants? And does father citizenship affect sons' old age mortality for second-generation immigrants? Naturalization was relatively easy before 1906. The Naturalization Act in 1906 tightened immigration policies, and the major shifts set out by the 1906 Act, as shown here on the screen, have more or less persisted until today. To become a US citizen, there are two steps. The first step is the declaration of intent, or the submission of first papers with a 2-year residency requirement. And after the declaration of intent is approved, a total of 5 years of residency is required. And the second step is to petition for full citizenship. The two steps procedure allow us to examine the temporal aspects of the citizenship effects. Women were not allowed to apply for their own citizenship until 1922. Before 1922, married women's citizenship was tied to their husbands. Between 1907 and 1922, women would even lose their citizenship if they marry a non-citizen man. In this study, we'll focus on men because of the unclear pathways of women's naturalization, and also because of the lower match rates of women between the censuses, as well as between the 1940 census and the Social Security death records. So there might be 3 main causal pathways linking citizenship and longevity. First, citizenship might affect longevity through its impact on labor market outcomes. There were arguably fewer labor market barriers for non-citizens in the first half of the 20th century than today, but empirical evidence has shown that a citizenship effect exists. There's an effect on occupation and education for both first-generation and second-generation immigrants. Second, citizenship might affect health by healthcare access. There are special requirements for non-citizens to access programs such as Medicare and Medicaid. And these health programs were established in the 1960s at a time when most of the first-generation immigrants in our study have acquired citizenship. As we examine citizenship status in 1940 and previous census years, the healthcare access mechanism is less relevant. And for the second-generation immigrants, as most of them were US born and they were US citizens, so this mechanism is also not important for them. Third, there might also be psychosocial pathways. Becoming a citizen not only signals social integration, but also fosters further integration. Becoming a citizen is associated with less perceived discrimination and a shift from immigrant minority to everyday membership of the US citizens, and therefore leading to better health and well-being. There might also be selection mechanisms. Immigrants might be in better health. Immigrants in better health might be more likely to naturalize because they're more likely to meet certain requirements, or they expect more benefits, such as better job outcomes or easier international travel. On the other hand, immigrants in worse health might be more likely to naturalize to access healthcare. There might also be return migration, the so-called salmon bias, that immigrant might return to their home country, and this is only for the first generation immigrants. But empirical research has found that it's not important for explaining the differences between immigrants and non-immigrants in the United States, as well as in Italy and the UK. And even if there is salmon bias, we argue this will lead to an underestimation of the citizenship effect, as those who are in worse health are more likely to return to their country and also less likely to naturalize. And researchers has argued that the selection mechanisms tend to be less important compared to policy changes. This graph shows the data sources we use. So we use data from 3 sources: IPUMS 1920, 30, and 40 full count census, and the Census-linked mortality death records. We use the DMF for males, and we use the census tree linkage for linking censuses. And this graph shows the age, period, and cohort dimensions. So for our first generation analysis, we have men born in between 1900 and 1912. So their age was between 18 and 30 in 1930. So we have their information on citizenship status in 1930, and then we also have their citizenship status in 1940. For sons in our analysis, they were born between 1913 and 1920. So their age was between 0 and 7 in 1920, and then their age was between 10 and 17 in 1930. And we also have their information when they were between 20 and 27. So this allows us to include their early adulthood socioeconomic status. So the mortality follow-up was between 1975 and 2005. Most of the deaths were above 65. It has very high coverage for those ages. And it is worth mentioning that the sons in our second generation analysis are not necessarily, and most likely not the sons of the first generation immigrant men, as shown in this graph. So our outcome variable is age of death, a month, and citizenship status is a set of binary variables based on the citizenship status in 2 census years. So for first generation immigrant men, we have 6 categories. So one can be a non-citizen without first papers in 1930 and then become a citizen in 1940, or still non-citizen but with first papers. So we expect that the citizenship, the differences in longevity follow this gradient. So those who were always citizen in the 2 census years, they had the longest lives, followed by those who were non-citizens with first papers in 1930, but became citizen in 1940, followed by those who were non-citizen without first papers and became citizen in 1940. And the reference group is those who were always non-citizen without first papers. Similarly, for the second generation analysis, we have father status in 1920 and father status in 1930. And we also expect such a similar gradient that I just described. We use birth year fixed effects to account for differences in death windows and state fixed effects to account for potential differences in the destination. We include English language ability, country of origin, race, years lived in the US, measured in 1930, Hispanic origin, marital status, and urban residence, as a lot of these variables are related to both the exposure of citizenship and also our outcome, age of death. For the second generation boys, we have a dummy variable for the immigration background, and for whether they were US born or foreign born, and a lot of them, over 97% of them were US born. We use 3 measures of the socioeconomic outcomes. The first measure is Duncan's socioeconomic index, and it's an index based on occupational income and occupational education. And we also use high school education as one of the socioeconomic variables, and also literacy for first generation men and fathers of second generation boys. These are the match rates. So for the first generation analysis, we have around 10% of the original population in the 1940 census in our final sample. And for the second generation analysis, we start from the 1930 census, and around 14% of them were in our final sample. So we use inverse probability weights to adjust for sampling bias. And these weights were created from models predicting the appearance in the final sample using variables from censuses. And in general, we use higher weights for individuals who are less likely to be included in the final sample according to our model. So our sample is more similar to the original population. So this table shows the results for the first generation men. Model 1 does not have SES as control variables, and we include SES variables from models 2 to 5. The change in the coefficients for the citizenship variables indicates the mechanisms through socioeconomic achievements. And the size of the coefficients follow the order that we expected, with the largest advantage among men who were always citizens, followed by those who had first papers submitted in 1930 and were a citizen in 1940. And in the final model, those who were citizens in both years live on average 7.5 months more than those who were always non-citizens without first papers in both years. We also find significant impact of father's citizenship on son's longevity. Comparing across models, we find that father's SES explain part of the association, and son's own early adulthood SES in 1940, including SCI and high school education, further explain part of the father's citizenship effects. On average, sons with a father in both 1920 and with a citizen father in both 1920 and 1930 live 4.1 months more than those who had a father, non-citizen father in both years. So lastly, we explored those effects, whether the heterogeneity across age. The upper panel shows the effects of being a citizen in 1940 on surviving the next 5 years, conditional on surviving to different ages. And the lower panel shows the effects of having a citizen father in 1930 on surviving the next 5 years for second generation boys. And different colors of the error bars and point estimates show the results from models including or not including SES variables. And overall, that we find a relative stable effects across ages below 70, an increase in effects between 70 and 75, relatively stable effects after 75, and signs of decreasing effects at older ages at around 85. So the increased effects suggest cumulative effects of naturalization, whereas the decreased effects at older ages might have resulted from mortality selection. To summarize, we find citizenship effects on immigrant men and their sons' longevity, and socioeconomic status partly explain the citizenship effects. Earlier naturalization is associated with more longevity benefits and stronger citizenship effects around ages where most deaths occur. So how big are the citizenship effects? In 2002, Jim Open and Vopel showed that the best practice life expectancy at birth increased on average 3 months per year over the 20th century. So our estimates show that the citizenship effect is greater than 2 years of improvement in best practice life expectancy for the first generation immigrant man. And the fact that father citizenship is greater than 1 year improvement in best practice life expectancy. And it's worth noting that we are looking at only older ages. So if we have a full range of age from age 0 to 100 plus, we would have greater different effects of citizenship. So what are the lessons for today's immigrants? And as a nation of immigrants, many of the contemporary US political debates are on immigrant policies, including pathways to citizenship. A significant number of current immigrants are unauthorized immigrants and those who hold twilight status, such as DACA recipients. And this lack of clear pathway of citizenship exacerbates their health disadvantages. Overall, there are more barriers now for immigrants to naturalize, and also a stronger connection between citizenship and labor market outcomes, as well as greater importance for citizenship for healthcare access. So we demonstrated here that naturalization significantly increases longevity for first and second generation immigrants who arrived in the early 20th century, underscoring the need of policies that facilitates pathways for citizenship for immigrants today. Ensuring early access to citizenship can promote longer and healthier lives. Fundamentally, inclusive immigrant policies will create a more equitable society where health and longevity of the entire nation are improved across generations. Thank you.